Hereby, I open this academic ceremony in which Joseph Piscopo will defend the academic thesis, Health Expenditures, Outcomes and Efficiency in the EU. May I invite you to present a summary of your study and the conclusions of your thesis.
Dear Prorector, dear members of the Corona, dear supervisors, dear family and friends, thank you for being here today and making this event possible. In the next 15 minutes, I'll provide you with a summary and main conclusions of my PhD thesis entitled Health Expenditures, Outcomes and Efficiency in the EU. The health expenditure financed through public funds is the second most important spending category in the EU. In recent decades, the increase in health expenditure across EU member states has consistently outpaced the increase in the gross domestic product. Against this background, in which governments have been caught between an ever more constrained fiscal space and challenging healthcare issues, this thesis aims to address the following issues: analyze the determinants of public health expenditure, and also study the relationship between public health expenditure and health outcomes. To answer these questions, this thesis applied a number of variables as inputs of the health system, which can be grouped as financial inputs, basically public health expenditure and out-of-pocket health expenditure, non-financial inputs, and a number of variables were applied as environmental variables to control for factors that affect health, but which ultimately are not controllable by health policymakers. In regards to health outcomes, the main variables applied are objective ones, namely life expectancy at birth and infant mortality. This thesis is divided into 4 separate studies, each one trying to address a specific question. Chapter 2 analyzes the existing academic research, focusing on the relationship between health outcomes and health expenditure. This was done by conducting a systematic literature review and meta-analysis. The third chapter analyzes the socio-economic determinants of public health expenditure, and this was done by applying static and dynamic econometric models, the dynamic model being the 2-step generalized method of moments. The fourth chapter analyzed the determinants, tried to identify the determinants of health outcomes, and this study applied random effects and fixed country effects regression models, applying the instrumental variables approach. The fifth chapter focused on technical efficiency in the EU health sector, and the methodology applied here was the stochastic frontier analysis. The systematic literature review identified 88 academic papers that investigated the relationship between health outcomes and health expenditures. Out of these, 78% indicated a relationship between these two variables. The most popular measure for health outcomes results to be life expectancy at birth, while in the case of health expenditure, the most popular metric applied by academics result to be total health expenditure. The meta-analysis indicates that the overall effect of health expenditures on life expectancy is 0.05, while the overall effect on infant mortality is minus 0.07. However, these results must be interpreted with caution due to the high level of heterogeneity that was identified. This high level of heterogeneity can be resulting from mainly 3 sources: different proxies applied for health expenditures and health outcomes, different study populations, and different explanatory variables applied by academics. The third chapter focused on the determinants of public health expenditure, and the main takeaways out of this study are: the first one, that the gross domestic product is the key determinant of public health expenditure. So basically, we expect that as an economy expands, public health expenditure increases accordingly. Secondly, we also identify that out-of-pocket expenditure is positively associated with public health expenditure. So basically, we are stating that out-of-pocket expenditure is complementary to public health expenditure rather than being a substitute. The governments during the election or prior to elections also result to increase public health expenditure as they engage in partisan behavior, and therefore they will be after more short-term results rather than longer-term ones, and they tend to boost the public health expenditure close to election years. Public debt also results to be modestly associated with public health expenditure, and in regards to institutional arrangements, we find the decentralization and gatekeeping as being positively associated with public health expenditure. Aging does not result to be associated with public health expenditure. In fact, most scholars believe that it is the proximity to death that is associated with public health expenditure. Similarly, government ideologies and citizens' expectations do not result to be associated with public expectations, with public health expenditure. In regards to factors associated with health outcomes in the EU, we find that the explanatory variables applied in this study exhibit a stronger association with infant mortality compared to life expectancy. Furthermore, public health expenditure results to be associated with better health outcomes. A 10% increase in the rate of public health expenditure is associated with an increase in life expectancy of 4.12 months and a reduction in infant mortality of 4.09 infants per 1,000 live births annually. In contrast to public health expenditure, out-of-pocket expenditure does not result to be associated with health outcomes. The non-financial factors linked to better health outcomes result to be education, diet, and the country fixed effects. Chapter 5 looked at the concept of efficiency across EU health systems. The aim of this chapter was twofold. Here we tried to identify the levels of efficiency across EU health systems and also to identify the determinants of the technical efficiency. As stated earlier, the methodology applied here was the stochastic frontier analysis. Results indicate that the technical efficiency levels between years 2000 and 2018 increased from 86 to 91%. Therefore, currently there is a room for improvement in what regards to technical efficiency of around 9%. Results also indicate that economic development is negatively associated with technical efficiency. So therefore, as an economy expands, we expect that the technical efficiency will go down. Education, contrary to economic development, results to be positively associated with technical efficiency. In regards to institutional arrangements, we find contrasting results, with decentralization being positively associated with technical efficiency, while gatekeeping resulting to be negatively associated with the technical efficiency. Looking at the countries that result to have the most technically efficient systems, we find Austria, Spain, and Estonia, while at the other end we find Luxembourg, Malta, and Ireland resulting to have the least technically efficient EU health systems. Summing up the main findings emanating from this research, we find that, first of all, as public health expenditure increases, mainly driven by the increase in gross domestic product, we expect marginal improvements in health outcomes. Secondly, a higher out-of-pocket health expenditure does not result in lower public health expenditure or improved health outcomes. Thirdly, the institutional arrangements in EU health systems result to be not constantly related to health expenditure and technical efficiency. In fact, we found that while decentralization increases public health expenditure and efficiency, gatekeeping, although also positively associated with public health expenditure, results to have a negative impact with technical efficiency. Furthermore, we found that population aging is not linked to increased public health expenditure. Finally, we also conclude that EU health systems can enhance health outcomes by using the same level of currently used inputs by around 9%. We concluded that this can amount to 9%. The policy implications that we identify are the following. First of all, policymakers should not base their policies on popular and simplistic arguments on the relationship between health expenditure and health outcomes. These simplistic arguments can be, for example, that if we increase public health expenditure, we can expect out-of-pocket expenditure to go down, or that if we implement gatekeeping mechanisms, these will automatically result in more contained public health expenditure. So it is important that policies are backed by academic research and not popular or simplistic arguments. Furthermore, more emphasis must be done on the efficiency indicators. Currently, the Eurostat publishes input indicators and output indicators, but there is no regular metric that is published to link both inputs and outputs. Finally, the education is identified as key driver of improved health outcomes and efficiency. The recommendations for further research that emanate from this thesis are that, first of all, there is room for substantial efficiency gain in the health sector. The importance of enhancing efficiency in the healthcare sector increases as economies expand and allocate more resources to their health system. So further research is being recommended. Obviously, more importance should be given to those countries that have ranked at the bottom levels of the classification provided in this thesis. And further research can also make use of more granular data that is available in the Eurostat health database. Finally, further research is recommended on out-of-pocket health expenditure, particularly in two areas. First of all, the positive relationship between out-of-pocket health expenditure and public health expenditure. And secondly, the identification of socio-economic factors that are associated with the out-of-pocket health expenditure. With this, I would like to thank you for your kind attention, and I give the word back to the Pro-Rector.
Thank you very much for this presentation. We will now start with the opposition, and the opposition will be opened by Professor Chabanovska, who was also the chair of the assessment committee of your thesis. She's Professor of Public Health Leadership and Workforce Development at Maastricht University.
Thank you, dear Pro-Rector. Dear candidate, I really read your thesis with great interest. Thank you for this very broad and interesting way of presenting the public health expenditures. I really appreciate different factors that you took into consideration while discussing topic in question, and also congratulations to your supervisory team. In posing the questions, I would like to concentrate on chapter 3, which was, for me, extremely interesting. I appreciate also your approach in which you show the determinants that have impact on public health expenditure, including gatekeeping, political preferences, out-of-pocket payment, and so on. At the same time, you show that you extracted the data from the system of health accounts, and there were seven indicators. And these were the curative care, rehabilitation care, long-term care, and preventive care, and also governance. And looking at the definition of public health, which is art and science of preventing disease, prolonging life through organized efforts of society, I have a question if, while looking at the indicators in such an aggregated way, where curative care also, of course, they all have impact, but what is your opinion about a little bit of camouflaging a very important element, which is preventive care? And as we know, this is a very small percentage of GDP in European countries, between 2 and 3 maybe. And how can we enhance the importance of expenditure on preventive care? And in what way, based on your results, can policymakers, those who make decisions, be persuaded to make some better shifts in funding?
Highly esteemed opponent, thank you for your kind words. As to your question, this study, as you rightfully said, does not go down at the levels of public health expenditure. It is at the aggregate level. However, obviously, further research is surely recommended at a sub-level, so dividing curative care from preventive care. Surely, the importance of preventive care is now on top of the agenda of the Eurostat. In fact, right now, I believe Eurostat is collating data specifically on preventive care, so apart from the system of health account submission. So clearly it is on the top of the agenda, the preventive care. And obviously, the importance of preventive care should be taken into consideration, should be taken into the context of the fact that curative care is cheaper than preventive care is cheaper than curative care. So obviously, in order to contain public health expenditure, surely a way forward is to promote preventive care. However, this research does not go into that particular aspect, but surely, as I said earlier, one of the recommendations is to use more granular data. And this is one of the ideas, that you focus more now not on public health expenditure itself, but on the sub-levels of curative care, long-term care, preventive care, and all those components that sum up to the public health expenditure figure.
And my second part of the question was how the policymakers can be better persuaded to shift funds to this type of...
Surely, sometimes preventive care may not have, may not get the attention that it deserves, maybe because preventive care generates results in the longer term, you know. So if you are boosting health promotion, for example, you won't expect results in the short term. But if you have long waiting lists and you're trying to contain, to reduce those waiting lists, obviously, if you dedicate more funds over there, you will obtain quicker results. So policymakers should make more pressure to politicians to boost the preventive care, so that ultimately we don't look at the short term, but we look at the longer term. And in the longer term, obviously, reducing cost from the public, from the curative care will surely be beneficial to the European member states as a whole, because ultimately we're seeing right now what's happening to France. I mean, if we don't control public health expenditure, I mean, in the long term, we can face more challenges which go beyond the healthcare sector and impact the economy as a whole.
Thank you very much. And maybe one more question in this direction. When you were looking at the indicators that would give us, that would shed light into the expenditure in public health area, were you satisfied with the indicators that are available? Or have you noticed that there is a need for the developing a specific indicator that would support data collection, and that is still missing or not developed? Is there anything that you have noticed that would be?
I don't. I use diverse sources, you know, not just the Eurostat database. But I'm not aware of any particular variable. So from one database or another, we managed actually, directed by my supervisors, to find the variables needed to capture what we believed can be a possible determinant of health outcomes or public health expenditure. So I don't have any idea.
You were satisfied with what is available?
Sometimes it was challenging to find a variable that is published regularly, for example, to have a trend to be captured in the study. But we managed.
Thank you. And now I have one more question. Yes. I would like to move to proposition number 4. Can I ask for reading the proposition?
Education plays a crucial role in improving health outcomes, as individuals with higher education are more able to make healthier choices that lead to longer lives.
Thank you very much. And my question is, you have stated different implications in your thesis for research, for practice, for policy. What about education? I know it is related to education of individuals, but can we also learn something here in academia, what we can include in our education based on your research?
Education is quite a tricky variable to include, you know, because of this endogeneity nature of relationship between health expenditure, health outcomes and education, because obviously better educated persons have more chances to make healthier choices. So, you know, there is this this relationship that is quite tricky. You know, Grossman, who was one of the leading authors in the 70s, I believe, if I'm correct, that studies this relationship, how education impacted health outcomes. But in recent papers that he is publishing, he is a bit cautious on this relationship, how education is impacting health outcomes, because there are other issues, for example, third variables that affect both health outcomes and education. So in academia, it should be treated with great caution, this positive relationship between health expenditure and health outcomes. So it cannot be so direct that just increasing education you result that in the long term you have health outcomes, because other variables surely have an impact directly or indirectly on the positive relationship between these variables.
Thank you very much, dear candidate. I give voice back to the prorector.
Thank you very much, Professor Chabanovska. The opposition will be continued by Professor Klasinga. He's professor of social medicine at the University of Amsterdam in Amsterdam.
Thank you. Dear candidate, first let me compliment you with your thesis and also your supervisors with undertaking this Herculean task. It's very broad to try to make a linkage between health expenditures, outcomes, and then use that via a lot of solid methods into a construct for efficiency. So, but I'm not here just to give compliments, so I want to just to question you on some of the steps that you take, because you take different steps, especially in chapters 3, 4, and 5, and you end up with a ranking of technical efficiency of EU countries. And I just want to question, starting at the beginning, are you using the right health outcomes? Is health outcomes, and you discussed it in the discussion, I know, but is health outcomes really avoiding death? Because that's what you seem to do. So everything we do in healthcare by bringing services, reducing pain, helping people with their mobility, and a huge percentage of all our healthcare is only very indirectly. It's more related to the experienced health. So I want you to reflect on that a little bit deeper. Is it really correct to use as health outcomes proxies of not being dead? Or what are the alternatives? And then I would like you to answer when possible in two directions. First, is health not more than not being dead in terms of activities in healthcare? And secondly, and you mentioned that too, but it's a classical public health, the contribution of healthcare to these negative outcomes is also limited. When I look at the scientific literature on the contribution of their changes, especially in the last 30 years, if I take the work of my colleague Johan Mackenbach, then I see that it is improving, but it's still relative. So could you just reflect on those two elements in how justified it is to take these two health outcomes as the main constructs of constructing technical efficiency?
Esteemed Professor, thank you for your kind words. In regards to your question, the issue of how to measure health is very subjective. That is all about, you know, how we define health. You know, just staying alive is a good measure of health, living longer. But bedridden, for example, is that health, you know? So what is health is highly subjective. In this thesis, we applied the most popular metrics that are used in academia, life expectancy at birth and the infant mortality rate. But as stated in the limitations, these do not capture the whole spectrum of what health can be. In fact, recent studies are focusing more on the quality of life, which tend to be more subjective, you know, because even what is quality of life can mean different things to different persons. But recently, there is more attempts. There are measures that are capturing more the quality of life. So for sure, future research, once we have more available data, these subjective measures can surely have more importance in academia, especially when you have highly developed countries, such as in the EU. So in the EU, you're expected to have some levels of infant mortality rate or life expectancy. So now the dispersion of data can be more in what regards to, and I believe more interesting information can be extracted from such studies that include quality of life as proxies of health rather than just life expectancy at birth or infant mortality.
Just quickly, and then we go to the second part, but do you think those are subjective measures? So the health measures that WHO is doing and the quality of life information we use for testing drugs and cancer care, and I would say it's pretty institutionalized, but we don't have on European level and all these data are easy available, so it would be impossible to do the type of analysis that you're doing. But there is, of course, and there are several ways of trying to calculate disability-adjusted life expectancies, which are there, quality of life, which is in the common ways of measuring the outcomes of cancer care. Basically, with prolonging life, it's not enough to measure, but we find that sufficient justification to spend a lot of money on it. And with the recent debates on value-based healthcare, we entered in the area of patient-reported outcome measures, where basically the value, as persons see it themselves, is taken up. So I agree with you. We would like to do, but with that, I probably weigh the limitations of the ones you have a little bit further. And that is also linked to the second part of my question: what is the contribution of healthcare to mortality and life expectancy?
Yes, sure. Looking at health outcomes in regards to life expectancy, I mean, can sometimes distort results, you know. So, for example, if I come from Malta, for example, we have a high level of infant mortality rate, so this resulted most probably in the fact that we have an inefficient health system. But because solely we apply this methodology. So yet again, there is this subjectivity because, and this is also reflected in the literature review, where we identify the high level of heterogeneity because different academics apply different metrics. So we ended up with results being quite problematic to pool and interpret together, because obviously we have these different metrics applied and resulting in high level of heterogeneity.
That I fully agree with you, but my conclusion of having the heterogeneity in your literature study would be to be extremely careful with using it as a construct that measures health outcomes, because it's so heterogeneous, and that builds it then for the rest of your studies, which, as I said, I very much appreciate, and I find the results, as you formulate yourself, intriguing. That was the word you used in the conclusions. But that brings me a little bit on the ranking at the end. Are these things solid enough scientifically to already say this is the technical efficiency and we can use this for ranking, and can what's
again the issue is what one believes to be the good measure of health outcomes. So if a country has a particular indicator that is good, but the other indicators are bad, but we applied only that indicator, obviously it's impacting on the generic. So this study should not be taken in isolation. I mean, it should be analyzed in the context of other studies that use different methodologies. You know, this particular study applied stochastic frontier methodology that currently is, but there are other studies applying other methodologies, mostly recently on the same approach. So this provides a contribution to this subject of efficiency. It surely cannot be analyzed in isolation.
I fully agree with you. My point is more that I think we need more work on the conceptualization and the breadth of variables that are put in the statistics, because the statistical model, it's good. But I would be hesitant in just saying this is the technical efficiency in which we can measure. But you made a great contribution to getting to that knowledge, so thank you for that.
Thanks, Ellen. Thanks again.
Thank you, Professor Klaasinga. The opposition will be continued by Professor Paulus, Professor of Economics of Education and Healthcare at Maastricht University, and she's present online.
Director, dear candidate, let me start by congratulating you on your thesis. I think you investigated a very relevant topic, and therefore I congratulate you and your supervisory team on this achievement. Of course, I also came across some questions, and I want to pick up the discussion where you just ended with Professor Klasenka. Because in chapter 5, that's my first question, is related to this chapter. You have this beautiful list in which you rank the countries which have a lower and a higher degree of efficiency. And that brings me to my first question. Of course, we can debate the methods, but suppose we just use this list and policymakers would have a look at your list. What types of policies would you recommend in this respect on the European level, knowing that we have countries with varying degrees or levels of efficiency? Would we need a European policy, or what would be your reflection on this?
Thank you, esteemed opponent, for your kind question. In regards to Chapter 5 that looked at technical efficiency, the methodology applied was a single step one. So it identified the efficiency frontier and tried to identify the determinants of technical efficiencies. That is what was the concept based on Bellotti e Lardi, 2018. One issue that results from the study that is quite interesting is, for example, the negative relationship between the number of beds and life expectancy. So that is surely a point that deserves attention. It results from other literature, this inverse relationship between the more beds you have, the shorter the life expectancy. And this can be resulting from different sources. I mean, if you have more, you have this information asymmetry, for example, that results in physicians having beds available and therefore making operations that can be quite risky. Scholars argue that these can lead to shorten the life expectancy rather than have a positive impact. So ideally,
we try to make it a bit more tangible. I read somewhere that you work at the Ministry in Health at Malta, and Malta on your ranking list scores very low qua level of efficiency. Suppose I would be a policymaker in Malta. What would you advise me to do as a policymaker based on the results of your research?
Yes. Again, in the case of Malta, the issue is the high infant mortality rate, mainly caused because in Malta abortion currently is totally unacceptable. So there is this statistical issue that in countries where you can do abortion, we count it as an infant mortality. So that pushes upwards our infant mortality rate. So everything must be taken into context, you know. But for sure, as tangible recommendations, there is surely the issue of having, for example, to reduce wastage. I don't know, excessive administrative costs, for example, that do not lead to positive health outcomes. There can be this issue that having better bed turnover, so that you don't waste resources in hospitals when you can easily transfer patients to less costly institutions. And making sure that you are utilizing your medical staff in an efficient way and ensure that outputs are measured and compared with those of other countries, you know, not just saying that we're good. everything must be compared. What is good in isolation when compared to other countries may not result to be so good. So making sure that your output is measured, and efficiency indicators for sure will help politicians and policymakers to compare results, not just saying we're good because we have a high total health expenditure, because having a high total health expenditure, but ultimately using those resources inefficiently, you end up with having outcomes that can be even better than you are saying.
And I agree with what you say about, let's say, the reduction of waste. You also had a discussion on education earlier. And you also showed that education is positively associated with technical efficiency. Do you think that one of the policies could be that on a country level, more money is dedicated to educating people instead of to healthcare? Would you think that would be a wise policy decision?
Yes, and education surely has a positive impact on health outcomes, but yet again, it must be interpreted with care. So, we should, as I stated earlier, this positive relationship should be interpreted with caution, because there can be other factors that are positively affecting education and positively affecting health outcomes. If I am more educated, I have better income, and I can afford a healthier diet, for example. I can afford to lead a healthier lifestyle. So for sure, a better educated patient can find more, for example, ways how to handle his treatments once he's unfortunately sick or something like that. So more funds to the education, for sure, lead in one way or another to better health outcomes.
Thank you. Given time, I give the word back to the prorector. Thank you.
Thank you, Professor Paulus. The opposition will be continued by Dr. Asopari Muscat, Director of the Division of Country Health Systems at the World Health Organization. And thank you for coming to Maastricht.
Thank you. Dear candidates, let me also join my colleagues by congratulating you on this ambitious work that you have undertaken. And I also congratulate the supervisors. I found several elements very interesting. Given where I am sitting now, I can see in this difficult, fiscally constrained policy environment where funding is being shifted in many countries to other priorities, including defense, that politicians and Ministry of Finance officials would be very, very keen to embark on any policy measure that would appear to improve efficiency in a short time span. Can I ask you to reflect on your dissertation and think of what would be your top preferred policy option to increase technical efficiency, and conversely, what would be your advice to countries as a policy option not to pursue if they want to increase efficiency, based on the strength and the confidence that you feel has emanated from the dissertation?
Thank you, esteemed professor, for your comments and question. Basically, currently, the health sector is undergoing again through a strain. In COVID times, we had the issue of COVID. Expenditure increased, so the benchmarks have gone up. Now we have the issue of defense. So the issues of defense now are closer to us more than ever. And obviously, if we have more pressure, for example, to increase defense expenditure, governments need to deduct from other sources. And sometimes health is one of the victims of all this. So it's quite problematic. And in this context, the topic of technical efficiency surely is more important. I believe that in regards to technical efficiency, we must ensure that, for example, we don't implement policies that are not backed by what research tells us. Because we can end up with implementing policies that, as I said in the policy implications, can be easy to understand, easy to provide to citizens, but they won't be realistic. For example, the issue of having gatekeeping to contain public health expenditure, because research is quite unclear on that, and this impacts negatively on inefficiency. So there isn't any particular one policy that can enhance efficiency, but a series of policies, a series of initiatives can enhance policies. Like we said, the issue of better use of beds, the issue of ensuring that we invest in more staff rather than in more beds. This was another conclusion that we have that emanated from this research.
So if I understand you well, you would counsel against a single measure, but you would advise for a basket of measures.
Sure, a basket of measures will have more impact rather than just singling a single one that can have an impact, but for sure it won't have the impact of a basket of.
You mentioned gatekeeping. Let me come a little bit to gatekeeping and primary healthcare. It's quite possible that somebody reading your dissertation could run away with the idea that primary healthcare contributes to technical inefficiency or reduces technical efficiency. How would you counter that argument?
On this argument, literature is quite mixed. So there are scholars that identify that gatekeeping in some way or another can control public expenditure, and others that did not find this relationship. There are others that found, for example, that gatekeeping coupled with other initiatives can contain public health expenditure, but not gatekeeping measures on a standalone basis. Obviously, gatekeeping is costly. I mean, you need to pay doctors. You need to have the gatekeepers must be paid. You need to have the system to block patients from going to more expensive healthcare levels. So that can be one of the issues that gatekeeping results in higher public health expenditure and more inefficiency.
In today's climate, where people can find all the information that they need and require, to what extent do you believe that gatekeeping can actually prevent people from accessing other care and services?
It is surely more difficult to control patients from accessing secondary levels of health and skipping the first level. This can be also analyzed in the context of high out-of-pocket health expenditure, because patients can resort privately to doctors, for example, to fast-track their access to the secondary levels of care. So that can have also a relationship, and this I believe is also mentioned in this thesis, this relationship between the patient and the doctor to skip the gatekeeper and access more expensive medical care. And this can obviously result in this complementarity that was identified in the research, where we find out-of-pocket and health expenditure and public health expenditure moving strangely in the same direction.
One last quick question. It's not only for Malta that you found lower levels of technical efficiency, but also Cyprus and Luxembourg. Any reflection whether there is a common factor because they are small countries?
Yes, for sure. That can be one of the factors that is resulting in technical inefficiency. You know, if a country is small, it has these economies of scale. It has this problem of accessing markets for pharmaceuticals at a more expensive prices. So that can be one of the factors, but there can be other factors as well, you know, because, for example, Luxembourg has a high level of economic development, so that also can have an impact. Cyprus, like Malta, has a high level of out-of-pocket expenditure, so that also has an impact on the out-of-pocket health expenditure. So these all issues lead up to countries to be inefficient. Most countries result to be from the southern part of Europe, where they have a higher level of out-of-pocket and a greater level of inefficiency.
Thank you very much, and I hand back to the Pro-Rector.
Thank you very much, Dr. Assopari Muscat. It's now time for the last opponent. It's Dr. Elissen, Associate Professor at the Department of Health Services Research at Maastricht University.
Thank you. Dear candidates, I would also like to congratulate you on a very thorough and timely dissertation, which addresses a relevant topic for European health systems, the relation between health expenditures, outcomes, and efficiency. And congratulations also to your supervision team on this achievement. I think you show in your dissertation that you do not only master a wide range of economic techniques, but I also particularly enjoyed the contextualization of your findings and the rich discussion with which you contribute to policy discussions. I have a number of questions, first of all, on your second chapter, where you present your systematic review and meta-analysis on the link between health expenditures and health outcomes. And while you find an association between the two, you also find very high levels of heterogeneity, which already entered the discussion a little bit beforehand. You mentioned also in your presentation that this heterogeneity is due to studies using different proxies, focusing on different populations and different explanatory variables. And I'm quite curious to hear your thoughts on how much of this heterogeneity could be reduced with different type of methods or with adjustment to the methods. So what would your advice be for new studies in this area to help with this heterogeneity?
Esteemed Professor, thank you for your kind words and for your question. Yes, a high level of heterogeneity was identified, and most probably this is the different proxies applied by academics to proxy health outcomes and even health expenditure is surely one of the sources of this high level of heterogeneity. And the heterogeneity was even high, even at subgroup level. Mm-hmm. So when we analyzed the studies, for example, capturing only those that studied total health expenditure by themselves and those analyzing only public health expenditure, the heterogeneity was still high, even though we tried to control by including categorical variables, for example, to try to lower the level of heterogeneity. The level still remained high. Obviously, this is one of the issues that we stated earlier. This subjectivity of the nature of health is leading to this high level of heterogeneity. If, for example, now the focus starts to, the attention of scholars will go on more on quality of life, for example, this heterogeneity will even go further, because we are now going away from more objective metrics to more subjective ones, and we are going to increase the heterogeneity. So ideally, there is some sort of metric that scholars, academia, believes that is a true measure of what can be believed to be health. Obviously, this is quite difficult to do, and most probably it may never be done. But obviously, unless this is done, unless we scholars use same metrics, this high level of heterogeneity will persist for sure.
And is it also, would you say that it is a matter of shifting outcomes mostly, or perhaps also the proxies that you use in terms of expenditures?
For expenditures also can be an issue, because even, for example, if we take public health expenditure, what is public health expenditure? As percentage of total health expenditure, as percentage of GDP, as per capita. So even when we say public health expenditure, this thesis is based on per capita, but other studies are based on per capita, on as percentage of GDP, as percentage of total health expenditure. So this heterogeneity persists at whatever angle you look at it.
Okay. So given the time, I'd like to also turn to chapter 5. And I think one of the results that surprised me in that chapter is about the link between decentralization and efficiency. So you conclude that decentralized health systems tend to be more efficient. And I'm quite curious how you explain this. So what kind of mechanisms you think, what kind of governance mechanisms, for example, you think would allow decentralization to support more efficiency?
This positive relationship between decentralization and technical efficiency was also identified by other studies focusing on a particular country. Most of them focus on Spanish and Italian regional health systems. And scholars argue that most probably this can be the result of, regions trying to do their best to be better than to have better results than those of other regions. So the fact that you have decentralization, you end up having different regions trying to do their best to improve their particular health outcomes. But obviously, the repercussion is that you end up with the issue of health inequalities then. So you have, for example, in Italy, you have regions with lower health outcomes, worse health outcomes than those of the northern part. Same thing in the case of Spain. Mm-hmm. So most probably this relationship between decentralization and technical efficiency is resulting from all this competition. Mm-hmm. Regions, regional policymakers doing their best to have better outcomes than those of other regions.
Yeah, so you identify some form of competition and perhaps also regional benchmarking and learning from each other in order to improve.
Yes, this is not my conclusion. What other researchers, when I try to compare my results to those of other scholars. Mm-hmm.
I'm wondering, did you consider that the relation might also be the other way around, so that more efficient health systems might sooner move to decentralization?
Well, you can give the answer later.
All right.
Joseph Piscopo, the time appointed for defending your thesis has passed. The degree committee will now withdraw to discuss the quality of your thesis and your defense. I request that you and your company remain in this room and await the results of our deliberations and our return.